That being said, my talk was about prognostic factors and milestones and monitoring. I don't think prognostic factors, the one we know, are still applicable in this area because of TKI, and therefore I changed my title to milestones, because once you respond, that is the major element of outcome. So in summary, what does matter in our practice today is for achievement of what we call the complete cytogenetic response is still the main prognostic factor for overall survival. Achieving a deep molecular response called major molecular response predicts for event-free survival, although there is no data whatsoever correlating with long-term overall survival. Now, with a more advanced technique, we get into a level where we don't see any more BCR-able cells. We're going to 10 to 5, and that's what we call today undetectable disease, or CMR. The implication is eventually one day we'll be able to stop therapy, although my short answer to you today is no, do not stop therapy outside clinical trials. So I'm going to start with a case, 35-year-old gentleman diagnosed with CML during regular checkup visit. No comorbidities whatsoever. He's doing well. He's not on any medication. And his doctor gave him imatinib to start. So he starts on imatinib therapy, and he comes to see you back at 3 months for assessment. He had a PCR done, and the PCR showed a value of 20% on international scale. His karyotype showed a partial response, or 20%. His karyotype is showing 40% Philadelphia positivity. So at this stage, at 3 months of response, what do you do? Well, there was some data from David Marine from England, very provocative, where it reported that patients who do not achieve 10% level at 3 months, they do very poorly. Survival at 8 years is 50% compared to 94% for those who are responding very well. So therefore, the reflex was, well, 3 months is great. We have to stop therapy. Well, one thing is, 54% survival is, I don't know what they do in England. Maybe they send them to Afghanistan or somewhere else. Still, without therapy, they do better. 54% is really quite low for control group. So I know 10% is it's a good threshold at 3 months, but that may not be enough. So second-generation TKIs, NSND and Decision, both established Nilotinib and Dasatinib to be better than imatinib therapy. So we have very good responses. No impact on survival. Same for Dasatinib. But more importantly, these trials have shown that second-gen TKI can induce a higher rate of optimal responses defined by 10% PCR at 3 months. 84% versus 64% for Dasatinib and Nilotinib, same at 6 months. And that is true as well for NSND trial, showing that Nilotinib can induce a higher rate of optimal responses. Therefore, what to do? Well, again, 10% has shown impact on outcome, and this is a summary of the Marine data, MD Anderson data, NSND Decision, and the Bella trial, where 10% usually they do better below 10% than it is above 10%. So the question is, shall we stop therapy at 3 months and switch treatment? And here a painting, and you look at the dog at the end of at the bottom side of the painting. What is the dog doing? You can say the dog is coming out. Or you can say he's sinking. Or you can say he's not moving, he's static. Therefore, having a value at 3 months, only one value, doesn't make any sense to make a decision. You need to follow the dynamism of this PCR. Do not take a single value of PCR at 3 months as major predictive factor for outcome. So in our database, when we follow this patient at 6 months, those who achieve a good response at 6 months did so well at the long-term outcome. So it's safe to wait till 6 months and see what the outcome will be. So you can check at 3 months response, but do not act on it, get an idea, and recheck at 6 months. At the last ASH meeting, Sue Branford from Australia did show their data where essentially they followed their patients, 500 patients, at 3 months and 6 months. What does matter in this table is, as long as your PCR at 6 months is below 10%, you do well. So do not take a 3 months threshold as a time to make a switch. Think about it, repeat at 6 months, and see what the outcome is at 6 months. So in this patient, we decided to keep the patient on imatinib therapy, and we recheck at 6 months. There was no mutation detected whatsoever. We kept at 6 months. 6 months came back, PCR is still 14%. So still above 10%. So we get an idea of how slow the response is. Patient is not responding well, despite having no side effect, getting a treatment every day, no mutations, so at 6 months his PCR is above 10%. Then we decided to switch therapy. And we elected to move to dasatinib. He's 35-year-old, no comorbidities. We started him at a full dose, 100 milligram once daily of dasatinib. At 12 months, he came back. His PCR is 1%. He's doing so well, no side effect whatsoever. Okay, he came at 24 months for his visit, and his PCR is 0.4% on international scale. He read all PubMed, he did his Google search, PCR is above 1%, above 0.1%, he's not in a major molecular response. He came to me, oh, shall I switch therapy, shall I do something else? Because I'm not yet at the level of what he called major molecular response. Then what will be your next step for this patient? Here the data from Germany published in JCO, where patients were categorized by response at 1 year, having a value below 0.1% defining what we call the major molecular response, 1% defining CCYR, and above 1%. As you can see, whether you achieve the value below 0.1% or 1%, you do exactly the same. So CCYR remains the major surrogate endpoint for long-term survival, and this patient has achieved the CCYR. His PCR is below 1%. Furthermore, this is our data from MD Anderson showing as long as you have CCYR, whether you have an MMR in addition or not, the outcome is the same. So bottom line, in your patient, in your practice, when you have somebody with a PCR is below 1%, do not act, do not switch therapy because they have not reached 0.1%. You need to make sure that your patient is taking his medicine and had no side effect and keep them on their medicine. This is data from MD Anderson, updated again, starting with undetectable level down to MR 4.5, MR 4, MMR, no MMR. No difference in outcome as long as you are in CCYR, and it's what we call transformation-free survival and overall survival. So again, measured goal, CCYR. This is data from the decision trial as well with dasatinib and imatinib. Both have shown the same thing. As long as you are in CCYR, having MMR in addition does not impact the overall survival. Now, recently there was a paper published from Germany this week in JCO highlighting that if you have undetectable disease, you may have better overall survival. We did not show this data, but keep in mind, as long as you have CCYR, you do so well. So then the question is, if I don't have an optimal response, should I consider a switch? And here the data from the LASOR trial reported at the last ASH meeting by Dr. Cortez, where patients on imatinib therapy who did not achieve an optimal response at 6 months, 12 months, and 18 months, were randomized between escalating imatinib to 600 milligram a day or staying on nilotinib, or switching to nilotinib 400 milligram twice daily, primary endpoint being CCYR within 6 months of the switch. Intent to treat analysis, there was no difference in the rate of responses between patients who remain on imatinib or switch to nilotinib. Therefore, again, do not hurry to switch therapy in somebody in suboptimal response. Furthermore, you want to have what we call undetectable disease. You want to have MRD negativity. This patient did qualify for this trial, and SCMR, where patients on imatinib for 2 years who did have minimal disease positive were randomized between staying on imatinib or switching to nilotinib. Primary endpoint being MMR at 12 months from the switch time, and we have a follow-up of 24 and 36 months. You can see you can improve the rate of CMR at 12 and 24 months, and 24 months is significant. 22% versus 9% on imatinib therapy. But look at the side effect and people who stop therapy, 16 to 9. Therefore, if you put them on a balance, there was no difference in outcome. So short answer today, for somebody with suboptimal response early on, keep going on therapy, do not switch. We don't have solid evidence supporting early switch in that sense. These are the recommendations of the ELN. Again, at 6 months, look at the failure. You need to have what we call partial response or 10% PCR. At 12 months, no Philadelphia and 1% PCR or below. Anytime you fail to reach this threshold, then you switch therapy. Do not switch earlier. Optimal are for research, but today in practice, do not consider a switch based on optimal criteria. We don't have data supporting the switch. Okay, now the problem with CML is we do very bad monitoring. In the US, these are data we published in last year, where essentially we have very bad monitoring. Only 25% did have a true good PCR on international scale. Some physicians did not do at all a PCR, or they do PCR in different labs, and these are not very valid. So we need to keep monitoring these patients very carefully and detect a loss of response early on in order to optimize the treatment down the road. So to make it simple, what we do at MD Anderson, 6 months on imatinib therapy, major response at 1 year complete. With second TKI, you may have early responses at 6 months having a PCR of 1%. So this patient responded, PCR 24 months, 0.4%. We did not act on it. We kept the treatment. At 54 months, he came with no disease left. And the question is, can I stop therapy? Here's the data from the French, the STEAM trial. An update was presented at the last ASH meeting. Still, 61% did relapse. No, they have molecular relapse, and they may respond to the challenge, but yet there is a relapse. And these patients are followed on a monthly basis with a PCR. So the short answer, can I stop therapy? The answer is no, not outside clinical trials, because one transformation will be a disaster for your patient. So practically speaking, how many patients we can stop therapy? Well, you stop therapy in patients achieving what we call undetectable disease. Based on imatinib data, 45% will have undetectable disease at certain time on therapy. Now, based on a French study, 40% will be able to stop therapy and do not relapse. Therefore, if you do a simple math, you will have around 18% of the patient in whom you can stop therapy. And this is one of the advantages of second-generation TKIs in the frontline, because you can have a height of deeper responses and eventually stopping therapy. Again, do not stop therapy outside trials. So there's pros and cons. The pros actually is financial question. It's very expensive. It's $6,000, $7,000 per month. In the US, $10,000. So it's quite expensive, and we really want to stop therapy. The cons is patients may lose their follow-up, and they come back to you after 6 months or a year with a blood transformation. So please do not do it. So monitoring, to be simple, you need to have a CCYR within the first year of therapy. And once you have CCYR, what we do in our practice, we do FISH and PCR together early on to minimize the risk of false positivity, false negativity. And once you have a stable MMR, we do PCR only every 3 to 6 months. Now, PCR may change, may fluctuate. Do not act in a major way to fluctuation of the PCR. As long as it is within 5-fold to 1 log, check for adherence, and do not switch therapy based on PCR. So do not disregard TKI unless there's a loss of CCYR. So PCR changes are common, are seen, and they do not impact the switch of therapy, and use a decent dose of the medication. Imatinib at least 300, Nilotinib 200 to 400 BID, and dasatinib 20 at least and above. How about mutations? When do we check for mutations? We check for mutations anytime you want to switch therapy. So mutation should be checked at the time of loss of response. Do not do mutation testing in somebody responding or baseline. You can detect minor clone that may not be relevant whatsoever. So check for mutation at time of loss of response. Why? Because once you know what mutation you have, you can tailor your therapy. If you have T15I, you go ponatinib and transplantation. If you have V299L, F317L, you avoid that. We go for nilotinib, and vice versa for nilotinib therapy. So anytime you want to switch therapy, check for mutations. Last word, I know you hear about it. Adherence is a major concern. 35% of our patients do not take their medicine on a daily basis. So please keep educating your patient about side effect and taking your medicine, because it can in fact impact their outcome. So I will stop here, and thank you very much for your attention.